Good afternoon, everybody. Sharing a few things about group practice. We all understand that, with the growing scale and the cost of our practice, it definitely is not a one-man show anymore. And group practice is perhaps one of the options to go forwards. Sharing our example, we started in a very different time when there was the disruption in ophthalmology. We started in '97. In fact, it started even back in the early '90s when my growing IOL practice was booming, and my friends would come, Dr. Basak, Dr. Sinha, Dr. Hajra. They used to come and help me in their free time to maximize my practice. The very reason that we started the group practice because we are based in West Bengal, and a lot of patients were traveling south and far for treatment. So we said that why don't we get together and have have a good hospital. So essentially it was on very strong human feelings and bondage, because they were my friends in college, 1 or 2 years junior to me. So we had a very good relationship. Essentially, I found one hurdle to overcome, and that was, like I was the big fish, and they were working as professors and lecturers in medical colleges, so they had to leave the security of the job. So I just, one fine morning, gave them this proposal that I leave my practice, we all join on a salary, and I'm disclosing our equity stakes. I hold 70% of the stakes, and my 3 friends hold 10% each. So it is still, even today, the same. And in fact, most of the opposition comes from the family. So I think that helped them to take the decision, and we started working together. So currently, of course, we are doing a big scale of work. We do 12 lakh paid patients every year, 85,000 surgeries, and we are 90 full-time consultants. The rest are employed whole-time, and we have 900 staff across 15 locations. This is what when becomes we. It is basically, if you say, what has worked for us is, this affiliation has kind of developed a faith. Faith is perhaps, and trust is the first thing that we transact in any relationship, any business. Whether it is the internal customers, the employees, the doctors. Why will anybody join our organization? They look at the core people of the organization, how trustworthy are they. Similarly, for the same reasons, patients and other people join the organization. So, where does individual practices lose out? The sleeping costs, like when the doctor is in the OT, the OPD is sleeping. And of course, the major thing is he becomes busy. And when he becomes busy, he lets go his brand. He can't see all his patients. And I couldn't see all my patients. So they filled in, and we evolved. Of course, and on the other hand, there are the problems of starting up, or the startup hiccups. So, and of course, if we want to acquire technology, which are costly, and if we want to scale up, I think we need to group together, because that's probably the only way. And then a retiring practice has its own, when a practitioner becomes 60 and there's no inheritance in the practice, then, there are problems which has to be sorted out on, recruiting people in the governance and in the holding of the organization also. So one model could well be that everybody has clinics, in a small city or There could be clinics, but these clinics do not have the critical numbers to start a tall comprehensive surgery center. So they can group together and form a surgery center. Here, one thing I would say that the promoter doctor, if he has, and he should be the change agent, he should propose the group practice. Otherwise, if the younger doctors get in the big fish, but probably, he thinks, oh, why have I gone into this mess? I was fine outside that. But if he says and the others join, I think the affiliation becomes much more stronger. And of course, when we look for these affiliations, it's very important that we talk to our family, our spouse, and get their consent, because a major objection comes from there maybe. And often we seek financial help, maybe from the building owner or something, and bring him into the equity. I have seen many group practices ending up because they don't understand the weight, and they don't have the passion to wait for the returns. They want it immediately, and that causes a lot of confusion somewhere. So as the surgery center profits, it is plowed back through redistribution in ownerships, meaning, if somebody is bringing in more patients from his clinic to the surgery center, the surgery center profit through him is more, and then his equities also keep on rising. I say this because, it is very difficult to have an assessment of, individual practices because of improper balance sheets. Let us have, the starting point becomes a little inaccurate. They might say numbers which are probably not there on the table. So after a few years of group practice, when the DNA has kind of settled in and a brand has been established, then other important things can be looked out. Financial transparency, as Vidushi told us, is the key. And all financial areas must be very clearly defined and spelled out before starting a group practice. The problem of inequitable practices and fee structures, like a big doctor or, more established practices, I think it can be kept in free forms because, and the surgery center may be looked at as a separate establishment altogether. Partnership versus private limited company, I would always choose a company because partnerships in any dispute can go into serious litigations. And of course, as I said, there are two splits of revenue, individual fees and the center cost and profits. And the profit gets invested, as I told you. And through this, many innovations and collaborations and subspecialties can develop. As it stabilizes, the group practice can work. The model 2, the same thing can start with youngsters who have passed out, and if they are good friends, they can start and carry forward this model. They can have clinics in rural and semi-urban areas and start the practice in the city. They stay in the city, and they can, because of they're young, they can use their time going out, and this is how they bring in patients to the surgery center. And the third model, of course, is a retirement model where a youngster can associate with an established model of 55-year-old, and he keeps on paying the retiring model through his earnings in the clinic, where the elderly or the he keeps on working less but earning more as a residual income by the footfalls and the area of the practice. And of course, we must develop asset-light models. We must hire premises. We can have a revenue share model with the builder, but outside the ownership. Instruments on higher costs, sleeping costs should be taken care of by building it brick by brick. Staff can always be put on multitasking. We must trim the system of all baggages, and Of course, you know, one thing is we must always leverage wealth for liquidity and borrow, even if we have wealth, because, you know, if the institute organization at any point becomes wealthy, then a sense of complacency sets in, and you know, the whole organization becomes, oh, bahut hai. Now, that should not be. Even if we have, we should keep on borrowing. And this is the last slide where I say that, you know, if it is, your practice is below 30 patients, you should look for a surgery center, which are there in many places. And then when you have 30 to 70, you can actually afford a surgery center. So that is the critical number where you coalesce. And with 70 to 150, you can actually have a full-fledged OP, full-fledged hospital requires almost 250 patients a day. And then above that, the diseconomies of scale start, and we can actually do something else. So we can take up the challenges of today by good affiliations of group practice. This is my message. Take it. I think you will be there are a lot of youngsters here, and you can